If I could just ask the group that's on the phone to go ahead and introduce yourselves. Joe, we'll start with you.
Hi, this is Joe Walton. I'm the Pharmacy Informatics Coordinator for Baycare Health System. And Julianne is here with me.
My name is Julianne Harcum. I'm the Nutrition Support Pharmacist at St. Joe's, which is a pediatric, NICU, and adult hospital institution.
Great, thanks guys. And Robert?
Hi there, my name is Robert Abda. I am one of the clinical informaticists here at Universal Health Services.
Yeah, hi, this is Tim Killian. I am the Assistant Manager of Pharmacy Informatics for Universal Health Services.
Hi, this is Reddy Yeruva. I'm the Associate CMIO for UHS.
All right, thanks guys. And this is Susan Armbruster. As I mentioned, I'm the Director of Business Development for Crossings. Since we have a lot to cover today, I'm going to keep this pretty short, but I just wanted to give you a little bit of background about who UHS, who Crossings is, and our relationship to Cerner and UHS. Crossings is actually a part of UHS, Universal Health Services, and we are located just outside of Philadelphia in King of Prussia, Pennsylvania. We have about 26 acute care hospitals that all use the Cerner system, and through our use of the Cerner system, we have developed a number of different tools via the MPage platform, including advisors and other tools that we have made available in a catalog to other Cerner clients. So through our use of the tools, we've developed tools that we felt were addressing challenges for our clinicians in their own hospitals, or perhaps there were areas where Cerner had not developed something yet, and when we felt that we were addressing some gaps that we saw in the system and potentially needed something more soon than Cerner was releasing it. So with that, we have developed about 20 software modules in the catalog. We'll be showing you the Tpn Advisor today, and also have a discussion with Baycare following the demo on their project for the Tpn Advisor and their use of the system. We do follow, as a Cerner client, we certainly understand the importance of following Cerner best practices for MPage development and implement these tools with the support of Cerner leadership. We have developed, in addition to the actual software that we have developed and the tools via the MPage platform, we also provide the implementation services for the software modules, including the design, the build, the training, and conversion support for your organization. We also, of course, provide the support services following the conversion of our tools at your organizations, and would work with you to troubleshoot and resolve any issues that you have with our software modules, and absolutely support you doing upgrades or changes in your Cerner code levels at your own organizations. With that, I will turn it over to Dr. Reddy to talk a little bit more about the Tpn Advisor and move right into the demo. So Dr. Reddy?
Thank you, Susan. Good afternoon, everyone. Thank you for joining the call. So I was planning to quickly run through a few slides, highlighting some of the key features we have built and why we did it, and also briefly talk about our adoption and the way we are currently live with the advisor, and then sort of show the actual demo of the Tpn on a test patient itself. So for years, we've been requesting Cerner for electronic Tpn ordering process. We have, since we have about 26 hospitals across UHS, we have different paper templates, and we wanted to make sure one, our goal was to try to make this a safe ordering process, make it electronic, and also try to promote variation reduction across all our hospitals, and then follow evidence-based practice. So that was the key goal for us, trying to take this on as a custom development on top of what Cerner gives us, because we didn't find that the Cerner was actually building anything to solve our problem. So what the Tpn Advisor does is it provides clinical decision support. We have, which you'll quickly see in a few minutes, we have reference ranges, we have guiding on ingredient dosing. We also have automatic ion to salt conversions. And we also accommodate various workflows such as showing you the related meds, showing you the labs which might be related to the TPN ordering process, and also actually interface this order into CAPS. Next slide, please. And we also have this across 34 hospitals, 20, I think Susan can highlight the details of it at the end, but we are 26 hospitals. Out of that, we have this live at 22 hospitals, and 4 are due to go live in June. And we predominantly have the adult version toned on. We are currently piloting the neonatal one, and then our plan is to roll this all our advisors across all our hospitals. The way the advisor functions is it has four different flavors based on the patient's age. From an ordering perspective, the provider would be ordering one order called Tpn Advisor, and then based on the patient's age, we flex which TPN to show to the user in the back end. And what this allows us to do is for each flavor, we have specific reference ranges and specific CDS support to accommodate that workflow for that particular age. Next slide, please. So in terms of adoption, we were able to do this education with a tip sheet from a physician perspective. Of course, we had WebEx demos for our pharmacists and for our nursing, but from a physician standpoint, it is very intuitive, and you're able to. We were able to address the education using a tip sheet, and we have more than 20,000 instances of TPN which has been ordered electronically, and that's more than 90% adoption across our hospitals. In early 2009, I think Baycare came on board. They looked at our advisor, and we went live earlier this year for Baycare, which I think they'll be sharing their feedback shortly at the end of the demo. Next slide, please. Or is it just the demo?
I think we're ready for the demo. So I'll pass the presenting rights over to you, Dr. Yaruva.
Sure. Can everyone see my screen?
Yes, we can.
Great. So I'll be spending I'm hoping to spend about 15 minutes to go through the demo, and then afterwards at the end, we want ample time. I'm sure I'm expecting a lot of questions just because of the complex process involved in TPN ordering. I'll leave ample time at the end for questions, but feel free if you feel that there's something which you would like to absolutely know and can't wait till the end, feel free to interrupt me. So we have a TPN Advisor order available in Cerner. Any user can go in and order that. Once you do that, you'll get a M-Page advisor window which opens up. I can click on the blue screen here, blue tab bar on the top, and make it a full screen. Navigating through the advisor, on the top we have patient demographics, and then we have patient information on the top, which has allergies, active medications. When I say active medications, these are medications related to TPN ordering process, not the entire med list. So anything such as IV fluids, electrolytes, propofol, or something which has high lipid content. So anything as an organization we felt was important to display in the active med section, we do that. And this is all configurable based on the organization. We have a BUN and creatinine and a trend of that right here. And then central versus peripheral. And then if your organization has both a custom product and a premix product, those will automatically display here based on your formulary. And then we have an infusion schedule. patient's weight. So if you notice, we have relevant labs which would be required for a physician to make, for a physician or a pharmacist to sort of make the judgment on how much a patient should be receiving. So we have relevant labs in each section for the volume, macronutrients, which would include fat, protein, carbohydrates, and energy. And then we have an electrolyte section, which also displays the lab values as a trend. And you also have additive section. And finally, at the end, if you need any comments to go to the pharmacist and to the nurse, you can certainly put their comments in here, instructions for non-lipid or lipid administrations. And then at the end, in the advisor, we have the functionality where you can order labs, which would be important to sort of order the TPN the following day. So if we dig into the details of how I order, so first thing I do is I can decide whether I want a central or peripheral. And if you notice, we have an osmolality calculator here. So based on what the user has selected, we display the osmolality for the solution so that if you exceed 1,000 or 950, you're not supposed to pick peripheral, you're supposed to pick central. And if the provider picks a peripheral, we alert them based on the osmolality limits, which are set as per Aspen guidelines, and recommend the physician to choose a central route. And in terms of the ordering, the advisor facilitates both premix and custom ordering process. So in this example, I'll start with the premix. So we know that in a premix solution, we have predetermined set of electrolytes and protein and carbohydrates. So the moment I select this, I can pick a volume here, and then what happens is, in this example, say for example, I pick 25 ml as my volume. The advisor automatically defaults the values which are present in that premix solution. And to indicate this is a premix solution, we have the locks here. So what this is saying is in 25 ml, which is 1,248 milliliters of the premix product, you have this much amount of ingredients in that product. We display the total amount of potassium that's going to be administered to the patient, the sodium, calcium, magnesium, etc. So say, for example, if I chose the custom route, because in my organization we don't have a premix and we always do custom, I can certainly change this to a custom formula. And then once I do that, based on the patient's weight, and you're going to input all the details of what a custom formula should be. The first thing we start is with the dosing weight. So we have a formula which is based on the Devine formula, where we default the patient's actual weight. And if I feel that this patient needs to be underdosed or overdosed, the user again has the option to change it to the appropriate weight. And once you do that, we pull forward that weight for the following day. In the infusion schedule, you will have the option to be able to follow your organization's default infusion schedule. At UHS hospitals, we have a 9 o'clock as our administration time, so we default 2,100 hours on the order. And if you notice it, we also have as a user, you can say how many overs you want the TPN to be administered over. And if you're an organization who infuse 2-in-1, where you infuse a lipid separately, you can certainly have the option to say, I want my lipids to be infused as a separate bag. And also have the flexibility to be able to say how many hours I want the lipid to be infused over. Coming to, if you look, we have the reference guidance here on the left. And I can, as a physician, even if I'm not completely 100% sure how much the patient should be receiving, based on Aspen guidelines, we give a reference here of what the patient should be receiving, the minimum and the max. So for example, for fat, I think here we have 1 because yesterday this patient received 1 because we default the 1 here. And I want to show you that for accidentally, if I type in 10, we also have safeguards in place where it would say that you're exceeding the maximum recommended for the patient. I'm going to revert this back to 1. So we also have hard stops, and we also have soft stops. I think I'll show you the soft stop in one of the electrolytes. And once I choose the weight and the volume, it breaks down the TPN, it calculates it. It's telling me that it's 1,100 ml of non-lipid per day, and then out of that, 275 ml will be given as lipid. So you have a breakdown of how much the patient would be receiving in terms of volume and an hourly rate, because it also displays the hourly rate here. Since when I'm choosing the volume, input-output is important, we pull in the input-output from the previous day so that you can adjust your volume as needed. So the macronutrients, the workflow is the same. So let me go ahead and choose 1 here. And for protein, if I say 0.8, and this is milligrams per kilogram per day, the moment I click out of it, it'll tell you how many grams per day the patient is receiving and how many calories that protein is contributing for the TPN. And at the end, once I finish my macronutrients, I have a total energy is 23 kilocalories per kilogram per day. And yesterday, I gave this patient 17 kilocalories per kilogram per day. And then you have a breakdown of the energy here, 42% fat, 13% protein, and 43% carbs. And you have a breakdown of the kilocalories here. So I'm going to pause here and see any questions on the macronutrients, volume, dosing, etc. Okay. So jumping into the micronutrient section. Since I started with the premix, you're seeing these odd numbers here because that's what a premix has, a predetermined value. So we pull in the total amount, but typically, otherwise you would have blank zeros here and say I can go ahead and say I want, and I have the reference range here, so 60 to 150. I'm going to show you what happens when I type in 160 here. So that's a soft stop telling me that you have exceeded the value. You probably should try to reconsider this. And now I'm going to go ahead and change this to 1600 to see what happens. Now I would get them clearly saying this is not a feasible value. I'm going to reset it to 160. So what I wanted to demonstrate here is the soft stops and the hard stops we have in place to make sure that end users are not making errors and to promote patient safety. So I'll go ahead and choose 80 milliequivalents here. And since I'm well within the range, now the color indication goes away. And I'm going to choose 100 of sodium. And what I want to demonstrate for the calcium is, say I choose 12 of calcium here. And then for magnesium, I'll choose 15. So phosphorus, we all know that the calcium phosphate product precipitates risk. So if I type in, let's say, a number which still not above, so let's do 20 here. Supposed to get I wanted to demo the precipitation risk. So if you notice, it says precipitation risk because the calcium and phosphate formula has exceeded. So in that way, we want to make sure that when this order goes across to pharmacy, we are already pre-checking the precipitation risk when the end user places the product. So I'm going to go ahead and change this back it's already reverted back to normal. From a chloride and acetate workflow, I know as a physician, most of the times I choose balance. So I have the options to choose a 1-in-1, 1-in-2, 2-in-1, or 3-in-1 based on the patient's acid-base status. Or if I absolutely don't want to give any acetate in my solution, I can say 0 acetate, or I can put in 0 in my acetate. And in that way, it will display based on what I chose that everything will be going in as chloride. One of the key functionalities when you get to these micronutrients or electrolytes is in the traditional form of paper, the providers were entering the salts and not entering the ions. So as a physician, if I don't have the expertise in order Tpn, or if I do not pay close attention, and I want to split my potassium between potassium chloride and potassium acetate, I have to do the math mentally or on a piece of paper and make sure I'm entering those two salts individually in the paper form, and at the end, double check to make sure that I didn't exceed the potassium while I was trying to solve the problem of an acetate or a phosphate. So for that reason, we automatically calculate the salts. All we ask the provider is to fill in the ions. And one might ask, how is the pharmacist going to get this order, and how are they? Because they have to pick salts when they are compounding a TPN product in the pharmacy or at the compounder. So for that reason, what we do is when we send this order across to pharmacy, we send them order as salts. And then in the comments, we also show the ions which the doctor has entered, so that one, the pharmacist has a view of what the physician has ordered, and two, we take over the math from the pharmacist because we send these orders as salts and not as ions to the pharmacist. Any questions on the salt electrolyte workflow before I proceed? Okay. And then finally, we have the additive section. We have guidance here, where we are able to provide guidance on the reference ranges, and then I can choose how much I want to give. So I'm going to just put in 10 of multivitamin to make this quick, and then I can add my comments here, and I can order labs for tomorrow. And then if your patient, if you're worried about glucose testing, we have a nursing communication order to start POC glucose testing if the random glucose is higher. So now I can go ahead and sign the advisor. We also have a proposed functionality. If it is a dietitian who sort of works on the order in your organization, we also have a proposed functionality where a dietitian able to propose it, and the doctor is able to relaunch the advisor in his workflow, and we default the numbers from what the dietitian did, and he or she will double check and sign that order to make that order active. So I'm just going to go ahead and sign this order and show you how the order looks like in Cerner. So if you notice here, we have the TPN solution here. And if you remember, we placed the labs for the basic metabolic phosphorus and mag, and you'll see those labs here. So we automatically have the advisor place those labs once you are in that window during the ordering process. And if I look at the order, this is another key safety feature we did. One, if you notice, we split the orders. We have a fat emulsion and the TPN as two separate orders because the provider said, I want this as a 2-in-1. So we account for that workflow, and we place two different orders. We split the volume of the fat to go as a fat order, and we split the volume of the non-lipid TPN, and we send that as a separate order. In the old workflow where we were in electronic, in EHR, and yet we had a paper process, we had a generic TPN order, which would come across from the pharmacy. Pharmacy would enter it in Med Manager, and then we would see the order because we need a placeholder in the Cerner for the user to know that there's a TPN running. And if you look at the verification process in the old system where it was on paper, one, the nurse had to, before administering the TPN, cross-reference what the doctor has ordered from the piece of paper and cross-reference what was dispensed based on the bag details of the ingredients. But if you look in Cerner, there's nowhere, if I go into an order as a physician, I would know how much potassium or how much magnesium or how much lipid is in this product unless I walk to the patient's bag and look at the label. So we wanted to take that away. So our new process is the nurse would be cross-referencing the TPN electronic order with the bag label and checking each ingredient. And this is how it would look. So we display each salt as a discrete field. So what essentially the nurse would be doing is cross-checking the sodium chloride. Is it 46.67 on the label? Is the sodium phosphate 40 millimoles? Is the potassium acetate 63 milliequivalents? So they're going to cross-reference each ingredient with the label to make sure that there was no error which happened either in the verification or the compounding process. And as a physician, when I go in, if my patient's potassium is high, and if I want to go and look how much potassium is in this bag, I can quickly look here that this patient has about 80 or 90 milliequivalents of potassium in that bag without needing to walk to the patient's bedside and look at the label itself. So now when this order goes into the Med Manager, you have, I think I'll ask Tim to tell you quickly how he sort of customized our TPN products, how he made it easier for our pharmacists to be able to identify those and make sure that they're choosing a TPN ingredient and not any potassium which is available. Tim, do you want to talk about that briefly?
Sure. What we ended up doing in FarmNet is we built out new individual products that all began with TPN that were listed at it. One of the reasons we did that was, one, we built a dummy volume called the TPN total volume, in which we then assigned our previous placeholders that we used for charging. So we maintained our previous CDMs and charging to maintain a revenue neutral process, and then we built out all the individual ingredients. There's basically no charge items, just for listing out in the order so that they would flow to the MAR for the nurse to be able to process, and it also help processes for the caps functionality on that. And we built out specific cross references for the caps on each individual ingredient. Dr. Eddy? Any questions, I guess, on the pharmacy build? The only, I guess, drawback with the advisor from a FarmNet aspect is when the order does come to FarmNet, it does require the pharmacist to do product assignment on each individual ingredient within the TPN. That's the biggest lift within FarmNet for the pharmacist.
Yep. Thank you, Tim. And we also have the CAPS interface. So what happens is once the order is verified in the Med Manager, the order goes across to the CAPS interface. And in the CAPS interface, I think the pharmacist would double check and make sure that everything is accurate, and then that pushes into CAPS. Correct, Tim?
Correct. Yeah. That's our process. We send it through our CAPS link. I mean, there is a functionality where you can send it directly from Cerner to CAPS. We maintain that intermediate process of sending the CAPS link and having our pharmacists verify it within at the local facility within CAPS-Link and before sending it on to CAPS for compounding. It just provides that additional double check to make sure everything's appropriate. Again, in addition to our decision to support that we have within the advisor within Cerner, we take advantage of the CAPS decision to support before it goes to compounding.
Thanks, Tim. I'm going to show you the following day, we make it very easy for the provider. So we default the values from yesterday. And when I mean yesterday, what you see here in current is not what the doctor entered yesterday, because there's always a chance the pharmacist will make changes to this bag, or just for the sake of volume or incompatibilities, solubilities, etc. So what we do is when we pull back these values, what we are pulling is from what has actually been administered to the patient, not what the doctor or the dietitian entered yesterday. We go back and look at the final product which was infused or administered to the patient, and then the advisor is smart enough to look at those ingredients and pull them back into the advisor for the previous day or the current day. The reason it says current here is typically for TPN, we are ordering for tomorrow. We're not ordering for today. So that's why in the current field, you see what is being administered to the patient. And then we automatically default those fields for you to be able to sort of make changes, because most of the times I have to make 1 or 2 changes on day 2, day 3, day 4. So we didn't want you to go through these every day. We pull back the numbers from the previous day, and you have an option to change them, and then quickly sign the advisor on day 2 or day 3. So this is essentially how we have built our Tpn Advisor and the workflow. So I'm going to, that actually concludes my demo. And I don't know if you want to take questions now, Susan, or should we do it at the end?
Let's go ahead and take any questions now on this, and then we'll turn it over to Joe to talk a little bit about the project at Baycare.
Sure. Any questions from the group? Any comments?
Good so far, thank you.
Hey, can you hear me?
Yes,
Hello?
we can.
Yes.
Hey, my name is Simona from Ascension Information Services, and I would like to ask you a few questions. Is this advisor here working in a context where there is a nutrition team that places the TPN orders like a pharmacist or dietitian? Are they able to use the same advisor to place the orders through?
So could you repeat that? So what you're asking is if the pharmacist or the dietitian is able to enter the orders and propose it, is the question, are they able to enter, or is the question, are they able to order the TPN?
Well, actually both. In some facilities, the TPN ordering, it's solely a service of a nutrition team versus a physician placing the orders. So these two, as a team, will have a consult from the physician, and then they will proceed ordering and actually placing the TPN formula like you just demonstrated in the advisor. Are other physicians able to use the advisor for ordering and placing these orders?
Yeah, so it accommodates 3 different workflows. The first workflow is what I showed. A physician can order it. The second workflow is where a dietitian has the privilege to actually place the order on behalf of the physician. So if you are an organization where once there's a protocol which says if I consult dietary, I'll give the liberty of to the dietitian to actually place the TPN order itself. In those use cases, we sort of we give the privilege to your dietitian so that they can actually go ahead and sign the order with a physician's name and a physician communication. So you would say this is a protocol, this is the doctor whom I'm attributing this order to, and then you can go ahead and sign. In that case, the order goes across to pharmacy because you have the privilege in your hospital. And then the third one use case is where a dietitian is only able to propose an order. That order has to be reviewed by the physician and signed off before the order goes across to pharmacy or goes across and be available in Cerner. That workflow is where you would propose it. And then once you propose it, the physician, it will go on to the physician's notification, and they're able to click on it. It opens the advisor for them, and they're able to sort of see the values you have entered and sign on it. Does that answer your question?
Yes.
Okay. Any other questions?
Yes. Do you have any flexibility in some of the micronutrients, and when you have shortages, can you lock down a field and say, we don't have this product, lock it down, so that they can't order it until you get product back in, or or change one of the nutrients because you've switched from one H2 antagonist to another?
Excellent question. So the way we have designed, I know this is also the same use case for us because we have 26 hospitals. We have our own formularies. We don't have a central formulary. Each one has different products, different stock availability. So what we did is in the advisor, in the back end, again, Robert can confirm this. He's our informaticist. So once you have it available in the formulary, so say, for example, you have a 1 ml trace element or 5 ml trace element or two different products, depending on your availability, if you hide it in the for the end user to order it, it automatically switches the product to the right one which is available in your in the Tpn Advisor. So what I meant to say is based on the formulary flexing you have in your hospital, the advisor automatically flexes to the appropriate product and appropriate ranges for certain things.
That's correct. That's correct. And you could even, so you could do it based on the formulary flexing, or there's a back-end configuration for the advisor. You could also hide it that way. And that back end is also how we add new like additives, for example.
Okay, thank you.
Welcome. Any other questions?
Does this send anything to the compounder?
Yes. So we have CAPS. We have interfaced our Tpn orders into CAPS. So as I was describing earlier, once the order is verified in Cerner, the order shows up on the, I think you send it to CAPS interface or it shows up on the CAPS interface. And in the CAPS interface, you confirm those products and get all the checks and balances there a second time. Because if you remember, we already have checks and balances during the ordering process. We have checks and balances in the Med Manager because I think Tim has built certain alerts there. And you have a third level of checks and balances in the compounding machine based on CAPS guidelines. And so once you verify those, you can push that directly to CAPS. So the short answer is yes, we have it interfacing and going directly to our compounding.
Yeah, actually, I think she's asking directly to the compounders, not going through CAPS, which we do not have that interface.
No, we don't. I should have let you answer, Tim, and stuff.
and I know, I think that's kind of a sticking point within Cerner out there. I see out there on UCERN. I think there's, a lot of question on the functionality of that. I think I have seen some stuff where some people have done a flat file type thing to the compounders, but we have not pursued that at this time.
And it's certainly doable, right, Tim, if an organization wants to do, because there's no reason if we can send it to CAPS, we wouldn't be able to send it to a local compounding. I mean, for us, since we have different workflows, we didn't want to do that, yeah. Any other questions?
Any other questions?
Hey, Susan, I just also wanted to make sure that the recording of this will be available.
Yes, absolutely. I'm recording the session, and I'll send it out to everyone that's registered. And if anyone from your organization isn't registered, but they would like to see the link, you can forward it on to them.
Thank you. I have one more question.
Go ahead.
When this gets sent over to the pharmacist to verify, if they have to product select every product, about how long does that take?
I don't know. Probably a minute or so. You know, it's pretty laid out. You know, we identify, like I said, we identified all our products in the selection window to begin with TPN, so they can identify them quickly. It depends on the number of ingredients, but generally, you know, going through 10 or 12 ingredients, they can generally do it in probably a couple minutes.
Okay, thank you.
Hi, this is Hope from Baycare, an integration analyst. I had a quick question about, we're running into an issue with getting the dispense order ID out at the same time as we're trying to send out the pharmacy order itself. Was there ever a plan for a dispense order, an RDS order with TPN, or is it just RDE? Does anybody know the answer to this?
Not me. I'm sorry. That's too technical for me. But we can follow up. So.
Hey, Hope, this is Joe.
With our interface. Yeah.
And I can answer that one. You can send an RDS with these. It's just that CAPS doesn't accept that.
Well, so CAPS doesn't accept it, but could we not send the original RDE, send the RDS and change it to an RDE, which we've done before for pharmacy. We've taken RDS messages and changed them into RDE.
Sure, we could just follow
and then maybe we can get away from that whole pause, wait issue and problem where we might not have a dispense order ID. We could take this off the call. I just had a question about it, though.
Okay.
All right, thank you.
This is Dana at East Alabama Medical Center in Opelika. I had a quick question. Is any of the information in the Tpn Advisor extractable that could be used into a patient progress note?
Good question. We haven't done that. I think it's you can certainly do that because all these numbers are stored, and we can create a smart template to pull those into which could be included in a progress note. Yes, but we haven't done that. Yeah.
Thank you.
Sure.
Okay, guys. I'm gonna cut off the questions quickly. I am certainly available if you'd like to send me anything after this, and I'll follow up on those answers. But I just want to be sure that we get to Joe and a little bit of a discussion on the Baycare project. So Joe, I'm going to turn it over to you here. Let me make you the presenter. All right, there we go.
All right, can everyone see my screen?
We can.
Looks good.
Okay. Sure, so my name is Joe Walton, the Pharmacy Informatics Coordinator for the East Region of Baycare, and I also have Julianne Harcombe here with me. She's the nutrition support pharmacist that was heavily involved with the project, with the design and testing. So just a little bit about Baycare first. We are a not-for-profit healthcare system. We're in the Tampa Bay area in Florida and also in West Central Florida region. And here's our kind of entire care continuum in Baycare. Of course, TPN is going to be in the acute care for TPN Advisor. Our post-acute care just doesn't have Cerner at the moment. So that wasn't an option for us to do home care with the TPN Advisor. But right now we are using it in all of our acute care hospitals. So here's an overview of all of our hospitals that we have here in Baycare. We do have 15 facilities. All are live with TPN Advisor except for the children's and women's hospitals at the moment, but I'll go over that here in a minute. And just a little bit about Baycare, our mission, vision, and values. Of course, always looking for these kinds of innovations to get towards healthcare excellence. So before we had TPN Advisor, we were using paper forms for each facility. We didn't have any ingredients listed electronically in the EMR. We would have, scanned copies of the paper orders. And we had that placeholder that would just say parenteral nutrition that would be entered into PharmNet with no details of what was in that TPN. We also had no standard for our TPN practices. We had some facilities using 3-in-1, some facilities using 2-in-1. We had one site with a TPN compounder making their own, while many others were outsourcing to CAPS. And then there were some smaller sites that were only using Premix products. So it was all over the board. So I think we had a lot of opportunity here. We also had one previous attempt at implementing electronic TPN orders, just with the native Cerner functionality using multi-ingredient IV sets in PowerChart. And, I think it was before I was at Baycare, but it was, I think at the first look, no one really liked that, bare essential look of a multi-ingredient IV set for such a complex and high-risk drug. So some of our must-have features for whatever we were going to do with TPN CPOE, we needed to have it in PowerChart, because while pharmacists are ordering all of our adult TPNs and a lot of our pediatric TPNs, the neonatal TPNs are being written by physicians. So we needed to have that access for them in PowerChart. We also needed to be able to see TPN orders and labs and kind of bring all that clinical decision support to the user in the advisor. We also needed to have some downstream automation and compounding. It takes time to transcribe all of these TPN orders over, either into CapsLink or into a TPN compounder system. So we wanted to make it time neutral for pharmacists and only have to make them enter the TPN order once and really do it in the source of truth, which is the EMR. So we kicked off the project last year. I think we had to wait a little while to get a domain. So, while the project only took a few months, we didn't go live until this February with the adult TPN Advisor. We also have the infant, child, and adolescent TPN Advisors planned to go live later this year, probably in September. So I definitely leaned on Julianne here a lot for a lot of our design and testing. I would say it's necessary to have an end user that's writing a lot of TPNs to really be there with you for this design. But we did pull a lot of the ingredients and Premix products that everyone was using to gather all the information from all their paper forms. So that was our starting point. And for testing, we ended up teaming with Crossings, our IS department, Pharmacy Informatics, and Julianne to test thoroughly all these scenarios. So a little bit about how we had no standardization before. This TPN Advisor project really brought about this opportunity. So all sites now are using CAPS. We built one CAPS template for all facilities so that it would line up with the correct units of measure, the correct sequence of the TPNs. So in this interim period when we're entering TPN orders manually into CapsLink, we're going to have that correct for all sites. We are also phasing out the Premix products. Some sites were using them and they've now converted to CAPS. So the variety that we had in our system, it's getting standardized a lot more now. We're also converting over to 3-in-1 TPNs for all adult patients. So that was another opportunity where we had a variety in practice across the health system that we could really consolidate and standardize. So current state right now, we have, I checked on the 21st, we had over 2,200 TPNs ordered through the TPN Advisor. I believe this is 100% of all TPNs. We haven't had any scenarios that I've heard of that we had to actually revert back to paper in the last month and a half. And we also have the CAPS interface project in progress, as you heard from Hope. So we are hoping that that interface is really going to bring us to a time-neutral workflow. Rather than having to write it on paper, enter that placeholder, and then transcribe into the CAPS link, entering it one time into the EMR and getting all the checks done there, verifying it in FarmNet, and having it go straight to CAPS is really going to help us with the workflow. So I think our lessons learned, standardize your practices first. We had a lot of standardization that we did as part of the project throughout it. So we had a lot of products that probably didn't need to be built in the beginning. If you standardize that and streamline everything first, the project can go very quickly and very smoothly. Also, as I said, bring in the end user input in all steps of the process. It's very useful, and I think it was Julianne that really helped our project be successful in a lot of design. Also, look at your impact to downstream systems. We had one issue that went on for a while with another interface pulling any continuous insulin infusion and considering it an insulin drip. So if insulin was in the TPN, our EICU system was seeing that as a continuous insulin infusion. So really just look at all those downstream systems, and if you're putting things into the EHR that were not there before as a complex order, that's just something you need to look at and test. And also updating the CAPS templates to the new units of measure. We were ordering in percentages before, and we really had to change those over to grams and milligrams and units. So that was something that wasn't thought of originally, and we had to kind of scramble the last week and get those added to CAPS. And that's all I had. It's been a very successful go live from our perspective. I think Crossings was great, responding to all of our concerns and putting in fixes and optimizations even in the interim between our go live and now that I think have improved the workflow for all of our users. So I thank them for that, and also for all the help on the Baycare side. We're moving pretty fast with all of this, and I think it was a very successful go live. So with that, I'll just ask if anybody has any questions.
All right. Well, thank you, Joe. I appreciate the recap of your project. We have just a couple of minutes left before the hour. Do we have any other questions from the group? All right, excellent. Well, thank you all so much for joining today. I will, as I've mentioned, I have recorded this webinar today, and I'll be sending out a link to the group for anyone who may have joined late or would like to share it with other people in their organization that weren't able to join today. Please reach out to me with any questions that you might have. I'd be happy to connect you with our team. Thanks, everyone, for joining. Have a great afternoon.